Okay, so welcome along, everybody. Thanks so much for coming. My name's Eleanor Brooks. I'm a lecturer at the University of Edinburgh in health policy, and I'm here today as one of the co-organisers of the EU Health Governance Network, along with Dr. Mary Guy and Dr. Charlotte Godrzewski. We are thrilled to be running what I think now is our 10th online webinar as part of the network. And I'm especially delighted that we're able to talk a little bit about economic governance and health as an area that I think is really fascinating. So I'm going to say a little bit about, very briefly, about economic and governance and health, just for anybody who's not familiar. This isn't necessarily an area that many people would consider part of health policy, so I don't think it's necessarily instinctive. So I'll give a very quick introduction, and then I'm going to introduce our speakers, and they're going to give us some more detail and sort of cutting edge research and progress in this area. So when we talk about economic governance and health, we're talking about a framework that was put in place in the aftermath of the financial and economic crisis from the late 2000s, early 2010s. To enormously simplify, this is a framework that involves the EU setting a series of objectives or priorities, member states developing plans about how they're going to meet or work towards those objectives and priorities, and then the EU signing off on those plans and having some input on those plans. I'm simplifying enormously. Our speakers will offer some more detail on top of that very basic framework. The purpose of the framework is to ensure economic stability. It's not a health framework. The idea is to avoid a repetition of the economic and financial crisis that we saw the first time around, if you like. It's therefore focused on very economic terminology, on deficits and debts and rules about what those deficits and debts can be. But it has enabled the EU erode into areas where it was previously not able to exert influence, health being a critical example of that, and the example that we are concerned with today. The recommendations that are made off the back of that framework are more or less voluntary, depending on the financial situation of the member states that we're talking about and that they're directed to, whether they are in receipt of EU funds, whether they have a strong or a weaker financial position. And indeed, I'm sure that the speakers will get to a little bit of that in their presentations. Initially, the framework was very focused on austerity. So the kinds of annual recommendations that we were seeing were very much focused on gaining control of public finances. And oftentimes that was through changes to patterns of health spending and reforms of health systems. And that was what initially, I think, alerted concern within the public health community with this framework, alerted people to the idea that this framework might be problematic. And indeed, some work started off the back of that. Some people are of the view that the process was socialised, so to speak, through the sort of mid-2010s, I suppose, particularly under President Juncker. This was when the European Pillar of Social Rights was integrated, for instance, when various changes were made to the process to better involve social actors. And we saw the introduction of various social scoreboards, sets of indicators on social issues, this sort of thing. Opinions somewhat divided, so certainly my own, as to the extent to which that counts as socialisation and has indeed played out that way. Ursula von der Leyen, again, a slightly different approach to this framework. From my perspective, it appears much more as broadening. We're including the Sustainable Development Goals within the semester now. The semester is being used to pursue those development goals, many more sets of indicators coming through. So in short, we have a really fruitful space for research. I think we still know, so far as I can see, relatively little about how this framework impacts upon health. Partly that's a time lag problem where it takes some time to see, but also my sense is that there is not a huge amount of research in this area. So I am thrilled to have the speakers that we have with us today to help us understand a bit more about this, and particularly to start sort of filling this gap a little bit. So yes, without further ado, Roland Erne is with us. I'm delighted, from University College Dublin. Roland is a professor of European integration and employment relations, and in this case, perhaps most importantly, the principal investigator on a European Research Council project looking at the European semester and its impact on health, particularly interested, as I understand, in labour politics and the possibility for transnational social movements that are brought about. But Roland's going to talk today in particular, or focus in particular today, on the extent to which the semester is following a script of commodification in health. So this idea of commodifying healthcare services. After Roland, we'll turn to Vania Putatti. Vania is with EuroHealthNet. And again, I'm thrilled to have somebody who's been working on this for so long. EuroHealthNet have been particularly excellent as a Brussels-based NGO at following the European semester. They've been analysing its content and its relevance to health inequality since 2011. And Vania is now the leading member of that team. And he'll be speaking today about a recent policy report that EuroHealthNet have released, which looks at the possibility for the semester to contribute to a well-being economy. So rather than pursuing the line that it has pursued thus far, I think it's fair to say, that goes in somewhat the opposite direction, Vania will be speaking to us about the possibility to turn that around and use the semester in a way that's more conducive to health. So I'm going to stop talking and I'm going to hand the floor to Roland, who's going to start presenting his work with Dr. Sabina Stan, and then we'll pass over to Vania and then we'll open up for Q&A. If people have questions as we're going along, please do put them in the chat and we'll start building a list, and then I'll put those to our speakers when we're done. Roland, in the meantime, the floor is yours.
Thank you very much for your invitation, and I'm very pleased to present the work, a 5-year-long work to understand the new economic governance prescriptions and their policy orientation. And in 4 countries, namely Germany, Italy, Romania, and Ireland, which we know well, which we speak the languages, which we know also the national debates. And that is very important because you don't understand the prescriptions without knowing the context in which they are formulated and which they're addressing. So we have looked at these prescriptions, but as you mentioned, we are not social policy scholars. So we are coming from sociology in Sabina Stahl's case and employment relations, and we are interested in broader topics of transnational action, democratization of the European Union, and in this context, we looked at transnational collective action of trade unions and social movements in healthcare, and that is a kind of our goal or our focus, or where we were coming from. That depends, of course, on the policy directions of EU interventions in the field. So if everybody is happy with what's happening at EU level, there is no need for protests, so that we won't see any transnational actions in this field. And then the EU interventions in healthcare also depends on what the EU is actually doing. So we need to start with a short introduction, and Eleanor started already a short introduction on economic governance and healthcare. And I think it's important to distinguish the nominal and actual competences of the European Union in healthcare. So if you have a very literal reading of the European treaties, the European Union has a quite limited field of intervention in relation to public health since the Maastricht Treaty. But if you actually look what the EU has been doing ever since, we have seen that actually no field of health policy is immune from EU interventions. And that happened despite literature literally stating that health should be a national competence, but that didn't prevent a kind of a spillover from other policy areas into healthcare. So we have seen a spillover for 2 reasons. One is the European Monetary Union and the EC accession criteria, which introduced fiscal constraints for public expenditure. And as healthcare is one of the biggest budget items, that has an impact. And the second one is the internal market and EU competition law, which affected state aid procurement law. Then we had an attempt that failed, that's why it's in red, service liberalization, the Bolkestein Directive, which aimed at kind of declaring healthcare a normal service in the internal market, but that produced the counter mobilization of trade unions and social movements, and healthcare was then excluded. But then we have some aspects of the commodifying direction of the Bolkestein Directive were kind of moved into more smaller directives and regulations in the area of cross-border care. So we have seen a increased pressure until the 2008s, mostly driven by horizontal market integration. But after 2008, we have seen, I think, a dramatic shift from horizontal market integration to vertical interventions in areas such as healthcare, which have been seen outside the remit of the European Union. And that happened in the framework of the EU's new economic governance regime. Why did I study that? One reason is that I'm in Ireland, and I had the chance or the doubtful privilege, so to speak with EU DG ECFIN people here early on in the Troika years in Ireland. And in Dublin Castle, we had a seminar with DG ECFIN people, and they were challenged by colleagues, but your free market ideology didn't work. Your free market ideology didn't create the convergence of economic and social policies in Europe, as you thought originally. And the answer was, of course, you are right. That's why we have to impose convergence by fiat. So because the market integration failed, we now have to do what the market should have been doing by vertical interventions. And this is done first in Ireland and Romania and other countries through the so-called bailout agreements, memorandum of understandings. But this has then since been expanded with the six-pack laws on new economic governance, the revised Stability and Growth Pact, the new macroeconomic imbalance procedure, which include fines if you don't accept or don't accept recipes or the prescriptions you get from these programs. You are fined because your bailout money is withdrawn. So that's the hardest fine. But then also with the six-pack, we have an excessive deficit procedure, macroeconomic imbalance procedure, which have sanctions which are quite high if you are failing to do that. But then more recently, also all EU funding is also linked to the implementation of this European semester recommendation. So although technically these are just recommendations, they are binding, and actually even more binding than EU law, I would say, because it's actually more effective to withdraw EU funding if you don't comply than to take a member state to court for non-implementation of an EU directive. So it is quite an important framework. So that's the first thing. So we have to accept that healthcare became an issue of EU governance. And an issue of EU governance, unfortunately, not driven by health ministers or parliaments, but by finance ministers and the DG ECFIN in the driving seats in the European Commission. Now we have analyzed what is the policy orientation of these prescriptions, and we see. If we just went through all the policy prescriptions for these 4 countries for these 11 years, there is something on resources, contain health expenditure on the left side. That was very strong, and it is also very detailed. It includes even prescriptions like reduced bed capacity. You would be surprised to read that, but because apparently, according to the treaty, management of healthcare should be a national competence, but that hasn't prevented the EU economic governance regime to prescribe reduction of bed capacity or hospital closures, also in some cases. But then we have seen also some decommodifying prescriptions more recently, but on balance, the commodifying ones were more important. But what is, in my view, more important is we have also seen, if you look at the organization and access of people to healthcare and the organization of healthcare, there is no decommodifying prescription on the organization of healthcare. All prescriptions on the organization of healthcare go into a managerialist or liberalization directive. So, and that is the case until 2019. So there is no socialization over the years. So the organization of healthcare clearly is organized in a directive that goes into a commodifying direction. In excess, we do see some prescriptions in a decommodifying sense, but we also see for the same country prescriptions that go in the opposite direction. So on the one side, Romania gets told it should give these Roma people better access to healthcare. At the same time, Romania is told to introduce co-payments for access to healthcare. So, of course, that is a contradiction. And then last but not least, there is this yellow prescriptions we have lined in the middle, increase the cost effectiveness of the healthcare system. That is addressed many times. It's the most important prescriptions. And that prescription, if you just read it face value without analyzing it in the context, in the semantic and policy context in which it is used, you could even say, yeah, this may be decommodifying, because if you are more effective, you can treat more patients, so you can do more with the same money. But if you analyze these prescriptions with the Commission reports and the national reports in its context, the message is clear. It's always meant to use less money and do the same stuff that you have been doing today. We can say the emphasis clearly on decreased access for people and worse working conditions, employment relations conditions for health workers, which we separated in a separate box, not in this presentation, not in this article. But of course, worse conditions for the organization of healthcare also affects workers working in them. But then what's also interesting is not all prescriptions have the same coercive power. It depends where your country is in these different corrective strands of the NAC procedures. Coercive power can be black, very strong, gray, strong, or weak. And then you see also that they are distributed in different ways across countries. So Italy and Germany doesn't get very detailed prescriptions, and if they get, they are not black, but Ireland and Romania gets very black prescriptions. So, and then there is also a different targeting across time. So most coercive interventions and most commodifying interventions were at the beginning, first 5 years. And this led some people to say that there is a socialization. But we wouldn't say that. We would say it's okay, if you have done the reforms, not having the same battery of attacks doesn't mean that it's necessarily more social. But then importantly, we also find this interesting difference across countries, and that can have, again, two possibilities. The country-specific nature of NAC could say, we take into account the different national differences, but what we see is actually the opposite. It's a common commodifying script, and then we attack the countries that are lagging behind in terms of commodification. So healthcare commodification has advanced in Germany and Italy with healthcare reforms in the 2000s already. So there was no need to introduce the commodifying reforms that they have already done in the 2000s. And whereas Ireland, Romania was lagging behind. So we see that, for instance, in the article, we show that private for-profit hospitals are very established in Italy and Germany, and not so in Ireland. And after the reform, we have seen a catching up of private for-profit hospitals in Ireland and Romania. So So again, an interesting indicator. So when a country doesn't get so many prescriptions, it doesn't mean that it's spared. In that case, it is, but most reforms have happened before. So what are the political implications now of this? So we are, I would be quite skeptical of the NAG regime, the country-specific NAG regime as such, because policy making is done by finance ministers and led by EU economic governance people that are located in the Commission and the DG Economics and Finance. Healthcare people are not a central part in the process. But most importantly, trade unions and social movements or European or national parliaments have no say in the NAG process. And then the country-specific nature makes it also very difficult for social movements to come together because, you know, why should we mobilize at the European level if now Ireland is told to introduce, as it has been doing, the case-paid DRG method of hospital financing? You know, we had that in Italy and Germany already before, but if there would be a European directive on DRG, I'm sure there would be a joint action of unions against it, but this salami slice tactic country by country makes it very difficult. So I would emphasize, I think if social people should put forward, should work with the normal democratic method, namely directives in Europe. And for instance, as there is now a European directive on minimum wages, social people should fight for a European directive on minimum standards for the provision and people's access to healthcare, because that would set an equal floor across Europe. Second, I would also be in favor of strengthening the protection of healthcare services from competition law. And the best defense against competition law is not to privatize hospitals, because the more private hospitals are, the more they are part of competition law. Then we have had currently the revision of the Stability and Growth Pact to ensure more high quality public services. Something has maybe been achieved, but I'm not overwhelmed. So after the suspension of the social Stability and Growth Pact, I think we will face another period of austerity in 2 or 3 years. And then last but not least, it's true that through the COVID funds, the EU has now even given EU funding for healthcare. But ironically, that is used in a quite Pontius Pilatus kind of way. So it is argued that as the EU has no competence in the management of healthcare system, you member state, you cannot use the EU funding to fight the staff crisis. You cannot use it for paying nurses better wages. But you can, of course, use it to build hospitals, as we do in Dublin, for 2 billion euros, which then profits the building industry and other industries, so it boosts private profits. So that is a danger. So what's next? So the risk is that we use EU money for healthcare, but for infrastructure, which then used for private people and not for staff. And actually, the money that you get through the COVID funds are, again, like the Troika programs, dependent on reforms. And we have seen marketizing reforms being used as a conditionality for the disbursement of EU funds. So in some sense, what we experience in Ireland, we give you money, but you have to do this and that. This hardening of conditionality is something that might happen now across all countries. Even Germany is now told if you want to get a EU COVID fund, you have to change your pension system, for example. So that will, in my view, it has led, we have seen, to a politicization of these EU interventions, which allows me to mention the book where we look not just at healthcare, but also water, public transport, employment relations and public services in general. And if anybody wants a PDF copy of the book, which I will send to press next Monday, send me an email and I will send a copy of that. And this is the last slide with our email addresses, Sabina, Stan in DSU, and me, Roland Erne in UCD, our website on the bottom. And also a sign that what we are talking about is not something just happening in the ivory tower of ERC research, but on the streets. So you'll see on the left side a demonstration of EPSU, healthcare people, which look at no commercialization, more staff, higher pay. And there is a joint campaign with a demonstration on the 7th of April in 2024. So the healthcare issue, it might become an important topic in the election campaign for the European Parliament as well.
Perfect. Roland, thank you so much. I have about 50 questions, but I'm going to control myself while Vania brings up his slides. That's really super emphatic and so helpful to see also examples of the CSRs. And so you mentioned CSRs about the number of hospital beds, for instance, that really help people understand the depth of what we're talking about and the degree of influence. Thank you very much. That's really useful. Vania, I want to hand straight over to you to make sure that we have plenty of time for questions, because I anticipate there are going to be a fair few. So if you're able to share your screen and get your slides up, I presume you can just override.
Yes, I'm trying.
Perfect.
Okay, are you able to see the slide?
Wonderful. Right. Thank you.
Okay.
Go right ahead.
Okay, thanks a lot. So hello everyone. My name is Vania. I'm policy coordinator at EuroHealthNet. And well, before starting with the presentation, I will quickly present the organization. EuroHealthNet is the Partnership for Health Equity and Wellbeing. We are an EU stakeholder organization representing health authorities from across the EU. We are based in almost all EU countries, and even other in the European region, with over 70 members at the moment. Our goal is to promote public health policies through actions on the social determinants of health and toward the reductions of the health inequalities. In other words, we look at health from a broad perspective rather than, let's say, narrowing down on biomedical aspects. And we focus on all these issues like the conditions where someone is born or the living conditions, or the more macroeconomic social structures that influence our health outcomes as they influence our daily lives and access to resources and etc. So talking about health and the European semester, well, Eleanor and Roland have been presenting already how more or less the framework works. Consider that when I refer to the semester, I normally talking about EU economic governance as well, as it does reflect the EU visions and economic goals as a whole. EuroHealthNet, as mentioned by Eleanor, has been providing feedback on the European semester since 2011, and more recently since 2019. Actually, when I joined EuroHealthNet, we have been developing in-depth analysis by pulling together expertise from across our membership through mainly interviews with the senior officers from across Europe. As you can see, our members are really public health institutions, to put together recommendations and feedback overall to bring to EU policymakers and pushing forward economic goals and our vision as a whole in the EU policymaking system. We then package these recommendations and this feedback, and we bring it at different level of governance, obviously with a stronger focus on the EU level, through various channels, including various occasions of policy exchanges under different format, closed door, open doors, with the collaboration with various institutions and etc. So in the interest of this webinar, I wanted to focus a bit more on what exactly we've been looking at when we are assessing the European semester, the EU economic governance, and what kind of feedback we've been producing and how this evolved in more recent times. So our main focus has been looking at the semester through the so-called health equity lens, or in other words, simplifying, we see how European semester outcomes impact determinants of health that emerge from the interviews that we have with our members, with the experts from our partnership. And then we identified specific, let's say, topical recommendation on what the semester should, let's say, not only recommendation, feedback in general on whether the semester was covering well or not enough certain topics, certain determinants of health, what we would like to see in the upcoming cycles. Consider these analyses are on annual basis. What direction they should take, perhaps putting more attention on developing indicators or allocating additional better budget, facilitating the allocation of budgets, and etc. But again, we were kind of developing recommendation within the rules of the European semester. In recent times, let's say, also given the momentum and let's say the evolution of the European narrative in recent years, we integrated this approach focus on social determinants of health with the recommendation also on how we would like to see the European semester in the future. Where should the EU economic governance go, what kind of objectives should be put forward vis-a-vis with the challenges that we've been facing over the past years, over the past decade, I would say. And we're doing so by integrating social determinants of health framework with I would like to say its natural evolution, the well-being economy approaches and models that obviously build not only on the social determinants of health, but on a wider range of other determinants, commercial, environmental, and etc. And well-being economy suggests models that put forward cross-sectoral intervention where actions take into account not only of the impact that one sector has into another, but actually they aim to have them synergizing in order to provide a new type of goal of the economic model, which is well-being. In other words, well-being economy, they propose a type of progress that goes beyond GDP, a type of growth that is sustainable in the long term, and the ultimate goal is not maximization of profit or similar other economic or fiscal indicators, but is well-being. Now, the well-being economy approaches or economy well-being proposes themselves as an alternative to our current, let's say, more neoliberal economic system defined by wide range of experts, described by wide range of experts nowadays as obsolete, as it puts forward objectives that do not take into account of the negative externalities and spillovers effect they have on society. They're based on the blind exploitation of human and environmental resources, where well-being is often expendable, and especially they fail in answering the challenges of our modern societies. And I think it's on this point where really well-being economy is becoming more popular. We do face long-term challenges, demographic change, raising of inequalities, or short-term crises. I mean, that they happen in the short term, and they also exponentially get worse very quickly, like the fiscal crisis, the COVID pandemic. But this system, the economic system we live in, fails in not only preventing the happening or the worsening of these conditions, but it also fails in making us prepared to face these issues. Therefore, there is no return of investments in the cost that the let's say this kind of neoliberal approach to economy brings. Now, this also triggered the interest not only of a wide range of, let's say, stakeholder organization focused on policy advocacy, but also the international community. OECD has been working on a well-being economy frameworks since a while, since a decade, developed metrics, frameworks for implementation at different levels of governance. The WHO is also starting working in the recent year on the topic. So let's say it's EuroHealthNet is the only one that is seeing the value of putting forward more well-being economy approaches. Now, the question is, does the well-being economy approach fit in the EU economic governance in the European semester? Well, if we look at how the narrative around the European semester and therefore the EU economic governance today, especially since the van der Leyen Commission that is about to finish, by the way, we see the willingness, at least in the narrative, to put forward an economy that works for people and the planet. This led to reform the European semester in a way where issue prioritization, again, in the narrative at least, is a reshuffle where economic and fiscal objectives are put almost at the same level of environmental and social ones. There has been the creation of the European Green Deal and further integration of its objectives in the European semester, strengthening of the European Pillar of Social Rights, the monitoring of the SDGs, as Eleanor said at the beginning, integrated in the European semester itself. And this also translated in various other, is spilled in other programs like the Recovery and Science Facilities, where they set targets related to Green Deal and European Pillar of Social Rights, for instance, among others, in order to access the various funding. So it translated in more, and it's not only in the semester itself. So we see that there are signs of, let's say, convergence between these processes, the EU governance and a potential well-being economy framework in it. But obviously, this is just in the narrative. This is what we have seen in very recent years, and now, vis-a-vis with the new institutional changes and with the context that potentially we will see, political context that we will see in the future, this still needs a lot of work. In EuroHealthNet last year put together a policy paper where we described the issues that I presented today. We also put forward a few recommendations to basically suggest a way to create a foundation, also in view of the next Commission, the next EU institutional change, for a stronger well-being economy in the European, in the EU economic governance, in a potential shift or a step forward toward a shift in objectives as a whole. So the creation of a well-being economy strategy and framework supported by expert group and with solid indicators that would allow to set out targets and objectives to monitor and foster through the European semester. And a political figure, ideally a vice president of the Commission dedicated on monitoring that these frameworks are actually in practice implemented in the semester and across all EU strategies and goals. So this is it from my side. Thanks a lot again. Happy to answer any question.
Thanks so much, Vania. That's super. Okay, we have a couple of questions coming in the chat, which I'm delighted to see. I'm maybe just going to start, because Roland, the questions for you are quite wordy, so I'm going to give you a couple of minutes to look at them, but I'm just going to start with Vania. So the question immediately, what are the main political obstacles you expect to realising the recommendations from the EuroHealthNet policy brief, and which strategic opportunities do we have as civil society to advance these points? I imagine you've been reflecting on that within EuroHealthNet quite a lot. Do you have any immediate thoughts on the obstacles that might be faced?
What we fear the most is that there is a lack of continuity in these, let's say, more social and environmental friendly policies that have been put forward by the Commission. And as well, let's say we have been living, although COVID brought some economic impact to the EU, the way it was approached by basically throwing money at the European countries to face the pandemic didn't really brought big didn't create a situation where we want to again just start talking about cutting and austerity and etc. Perhaps also people will forget about what were the priorities and what were the conditions that we faced a long time ago. So yeah, it's mainly going to be the issues around the political context and the future, what will be prioritized. Hopefully social matters will still matter. Civil society should simply engage and keep, putting forward messages toward a stronger inclusion, especially the need of bringing social Europe, the values of the social Europe at the core, even of a, let's say, more conservative Commission in the future.
I think that the point about the temporality of the issue being raised up the agenda, we've just seen $1 billion cut from the EU for health programme, right? Despite that having been received all of this political will and attention and all of this money in the aftermath of COVID, and then even already by the beginning of 2024, we're €1 billion down because the priorities have shifted and the money goes somewhere else. So managing to maintain that commitment to well-being economy when it's just in the narrative, as you've described, seems to be a real risk, doesn't it? Roland, I want to hand over to you because you have two questions. Maybe we could start with Catherine's. How do you explain, or what do you make of the contradictions? Indeed, so sometimes these recommendations are commodifying and sometimes de-commodifying. Could you say a little bit about what you think the rationale behind that is?
Catherine and Rosella is actually going in a similar direction.
Similar question.
So start with Catherine. How can we explain this contradictory advice? I mentioned in the talk the prescription, please increase access to healthcare of Roma people and people in rural area to healthcare services. At the same time, Romania getting a prescription, please introduce co-payments for users of health service. Obviously, they are contradicting. And the reason behind that, of course, is that it is a composite document. So when you trace it back where the documents come from, the co-payment part of the prescription comes from DG Economics and Finance. They look at it from a finance point of view. We need to have more money for public or less expenditure for healthcare. And then the other one comes from an activist in DG Employment who is working for Roma rights, etc. And then in the end, because we have now the narrative that also Vania mentioned, we need to do both. We put them together back in the same prescription, but they don't have equal weight. And that's the problem, because the economic and financial prescriptions are backed up by the six-pack on economic governance, the Stability and Growth Pact, and the macroeconomic imbalance procedure. When you don't do it, you risk fines. On the other side, the social prescriptions are just mentioned in the Europe 2020 strategy, which is not legally binding. So therefore, as we have seen, until the COVID crisis, there was a clear misbalance of power between the economic and financial recommendations on the one side and the social side on the other. Now, has this changed with the recovery fund? Yes and no. In the recovery fund, now social prescriptions are one of 6 criteria that can be used to check whether you're dispersing European money. And that has been used, for instance, in Romania to get a change in the labor law, which is more labor friendly, because that was a conditionality for the Romanian government in 2022. So if they had to change the labor law in a more social direction to get recovery money. The problem, however, is that in Italy and many other places, the most prescriptions, or actually almost all prescription about the organization of public services are still driven by this commodifying, the market is better approach. So marketizing healthcare, public sector reforms are still very much on the card. And then you see that, for example, very clearly about the funds. So there are other conditionalities. So at the beginning of the discussion about the recovery fund, some healthcare people wanted to have an allocation for health. It's COVID after all, so we need to have a percentage of the funds for healthcare. That was rejected. Instead, we got a percentage, quite a high percentage for IT companies for the digital transition, as if Google would be the biggest loser of health, of COVID, you know, possibly the opposite. And then we see it also in the legislative agenda. So what is the European Commission doing in healthcare? In the legislative realm, it proposes the health data space regulation, which says in its first articles, this is a regulation that should help creating a European market in healthcare. And it's based on the market mating article of the treaty. Whereas there are some social developments in some aspects, I think maybe minimum wage directives, I don't see them in terms of commodifying orientation, marketization of services. And the last point that Rosella said, yeah, what should we do next as researchers? So we did analyze in the book, which really I can send you. So send me an email and I send you a copy free. I can do that because it will be open access anyway in May. So the problem is that you have to really to read and analyze these prescription in context, because they use very good in the rhetoric, as Vania says, but what it says sometimes is not necessarily what it does. And researchers should just look what is actually happening on the ground and then outline these contradictions. I think that is something we can do.
I think that's really, really key. And part of my experience with this is that's made difficult by the language issue, right? To actually be able to look at this across, it's pointless unless you look to the national level, and that requires a language competence that many of us do not possess. And also your point earlier, Roland, about reading it in the context of the country reports as well. There's quite a lot of research that looks simply at the recommendations without looking at the context of the documentation that supports them, which the member states will be required to use when they interpret what these things mean. So it makes no sense to do them separately. That's really helpful. We have some great questions from Alec from the University of Amsterdam. Again, I'll start with Vania at the bottom. Is there a worry that a well-being economy will fall into the trap of neoliberal individual consumerism, i.e. consume your health rather than actually being the pursuit of health? Any thoughts on that?
Well, so the point around the economic well-being is they put you in a context where you don't get sick in the first place. So, and whatever policies are put there, they take into account of the negative impact that they may have on other aspects of societies. So it's really like the most common example of, let's say, the most famous example of well-being economy is the Cater-Rateworth Donut economic model. And then you really see where it should, what an ideal well-being economy would look like. So honestly, I don't think so. and especially if it's then backed with the right amount of expertise, indicators, and so on and so forth.
That's probably the key, isn't it? And when we look at historically the Commission's ability to interpret things like wellbeing economy in the way that we, particularly from the academic side, feel they should be interpreted, that might give us some pause for thought, which I guess is what Alec is alluding to. Roland, there is a question for you. EU seems to have adopted neoliberal goals with social goals as a secondary consideration. Indeed reminds of the just-in-time system that many insurance and hospital systems in the US have implemented. Has elite capture or other forms of lobbying played a role in this turn? I think that's a fascinating question. Do you have any, did something come up in your research on this?
What is interesting is that what happened is not the shift to new economic governance is actually not something that was planned ahead by business interest. So they were forced to it somehow. They wanted actually, neoliberal theory, at least in textbook, is we just create a market and then social and employment standards will adjust automatically to market forces. But the really existing market forces didn't lead to harmonization, but the really existing market forces led to economic imbalances that threatened to explode the euro or explode the EU as a whole. And only at that time, Business Europe and other business organizations, which we interviewed in 2007, they said we are against governments. Only in 2 years, they completely changed side and agreed that the EU should intervene in employment and social policy areas. Before, they were against any EU intervention in this field because they were thinking the market will harmonize it anyway. So why were they against initially? They were against initially because it's much more difficult for trade unions to politicize markets than it is to politicize commodifying interventions. So in some sense, the shift to EU economic governance is also a problem for management or an advantage for social movements. And because now all these neoliberal ideas become a matter of political interventions and can therefore be politicized. And that's why we have seen in the book, we show an incredible increase, a substantial increase of transnational protests of public sector workers, also in the healthcare sector, which is surprising because normally we think public sector people wouldn't reach out across boundaries, but they were very more active even than metal workers in transnational protests in Brussels in recent years. And the reason for that is that these kind of commodifying prescriptions become an issue of politics. They try to prevent politicization by doing it in a very technical language, by doing it country by country, by doing it salami slice tactics, but it's still political and therefore, in my view, easier, and that's maybe a positive note, it's easier to politicize that than the market forces. So in the 2000, Schröder did the German healthcare reform by saying we need to limit payroll contributions to the healthcare sickness funds because of competitive market pressures. Our wage costs are too high, so we have to reduce the sickness fund contributions. And so the marketizing reforms were introduced because of these horizontal market pressures. Now they are done with these political pressures, which is not better, of course, but it's easier to politicize. In that sense, hopefully there is a basis for, the fact that we discussed this and we politicized this 10 years or 20 years ago, there wasn't any European seminar on the healthcare reform in Germany, for example, at the European level.
I think exactly what you're touching on there is the reason that I wanted to have both of you as speakers today, because I think I recall that when the health community started paying attention to this in 2012, 2013, it was very difficult to mobilize health NGOs around this issue because it wasn't anybody's central area of work. It was seen as quite far away from what people were doing in their day-to-day. But I think there's so much to learn, and EuroHealthNet was always an outlier here, right, and paid much more attention much earlier than many other organizations, and helped a lot in that way. But what Roland's saying, and what could be learned from the trade union movement about politicizing around this issue, and that there's real cross-sectoral isn't quite the right term, but there's real learning to be had across these different groups about mobilization around what is quite a vague and fuzzy issue for health, I think, or aspect of health. I've put out a last call for questions. I'm not seeing loads more rolling in, but I think that might just be because we're also overwhelmed with the scale of what needs to be done in this area, which was the purpose of bringing everyone together anyway, which is wonderful. I mean, just to finish maybe on this point that was raised about the gap in the research, there's so much to be done here. I mean, we haven't even touched upon really what difference has been made to this system and this process by the recovery and resilience plans that member states now have to draw up, which have been integrated within the semester. So now you have the sort of semester set of recommendations, but that's integrated with the plans that states have been required to draw up to spend their recovery money, their COVID recovery money. We haven't talked about the reform of the economic governance framework, which is due to go through later this year or beginning of next year, which will change the system again. We haven't even touched on what difference any of that will make. There is a huge amount to be done here, both at European level and at national level. So I hope that we'll continue talking about it for some time. But for now, thanks so much to both of our speakers, to Roland and to Vania. We really appreciate your time, and those presentations were fabulous, as everyone has been commenting in the chat. And to everybody for coming. We will put the recording up very shortly. And one final note, that I think if people want to hear some more from Roland, you're in a webinar on Friday, as I understand. Yeah, I'll maybe link to I'll do a Twitter thread when we finish and just link to the registration for that, in case people want to hear Roland speak a bit more about the sort of social movement side of this research project as well, rather than focusing so much on the health, which I think will be really interesting. Super. All right. Thanks so much, everybody. Good to see you all.
Thank you. Bye-bye.
Thank you.
Bye now.